Education Manager at Cochlear UK. Charlotte brings a wealth of experience from her previous NHS roles as a hearing therapist and senior clinician, and today leads on referral education, helping ensure audiology professionals stay up to date and patients receive timely referrals and support. Please join me in welcoming Charlotte.
Hi everyone. Thank you so much for coming and bearing with me on your Monday evenings. It's lovely to see so many people kind of dripping through as part of the world of Teams, and it's lovely to see some familiar names coming up. It's very lovely that I've also got Matt on the screen over here, and there'll probably be a few things that might resonate with a few of you that I might have had discussions with in the past, or potentially even have had the I don't know what the word, a challenging experience of being one of my students a long time ago. Who knows? Well, anyway, okay. So my name is Charlotte Rogers, and thanks to Jayne for that lovely introduction. By clinical background, I'm a hearing therapist, and no one is allowed to think, oh, are they still in existence by now? They are. They absolutely are. And that was many moons ago, kind of in the early 2000s. But as part of my role, I did a lot of work with people who had severe, profound, or more complex hearing losses, and often they were perhaps the group whereby, if I'm honest, audiologically, we'd got to a point where someone would sit and think, actually, you know what, we're kind of at the end of a point now in your hearing aid prescription, in your hearing aid journey. What's next? What are our options? What are we going to explore? I was fortunate in that I worked across a service, so I also worked with our implant team at the time, and developed a real passion for everything cochlear implants in adults, and particularly in adults. And I suppose as well that what sort of stirred the passion in me was that I could really see the amazing outcomes for these individuals that went through that pathway. And it's something I've kind of clung on to for a long time. After around 20 years in clinic, I moved over, and then I was a senior lecturer in audiology at De Montfort Uni for about 6 years, and I've been with Cochlear for the last 2. So my role in Cochlear is very much around how do we work to support all of you out in the profession to provide the best awareness, best support, best education that you can have for your patients. What does that look like? How does it work? And how do we raise awareness? And we'll come on to perhaps some of the importance of that awareness throughout the next hour that we've got together. The first thing I'd really like to do is get you to just have a think for yourself. You are more than welcome to put your response in the chat if you'd like to. Have a look at my rubber ducks. And what I'd like you to do is just think of my rubber ducks a little bit like a visual analog scale. So if tomorrow you're sat in clinic and you see a patient for whom you think, perhaps we need to be thinking about a CI referral, how are you feeling about that? Are you kind of more like my number one? So are you floating on the top of the surface, really confident, I know what I'm doing with this, it's all great, no problems at all, I'm on it, I've got the admin down, I've got the discussion down, I'm very confident? Or perhaps you're more sort of in that middle section, maybe 4 to 6, where things are about a bit blurry, but you can work it out. Or perhaps you're more like kind of 7 to 9, where it all feels a little bit overwhelming. You're not really sure what to do. And it's a challenging task, and you've got to kind of go back to all your information to try and remember. Thanks, Jayne. Yeah, it's important to just have those moments to think for yourself around. Often we don't know what we don't know. So where are those gaps in the knowledge? Where are those gaps in awareness? And what do I need to do in order to fill them? Wonderful. Okay. So as part of any presentation that we do with Cochlear, we're asked and tasked to talk about our mission. And initially, if I'm honest, it was something that didn't come so easily and quickly for me, having been someone that's worked in the public sector all my life. But actually, this stuff is so fitting for where we are now. I'm here, and we're all seeking to empower people to connect with others and live a full life. What does that mean? And the very fact that you've come onto this webinar shows that you have that intent and you seek that empowerment for your patients. We want to transform the way people understand and treat hearing loss. And that very much fits into the referral agenda as part of cochlear implantation. How do we start to raise awareness, educate differently in order to help people understand it more and perhaps break down some of the stigma around those kind of referrals as well? And lastly, innovation. So how do we as a team together innovate new ways of developing pathways, of making those connections, bringing people together so that we can get the right person to the right point at the right time for them? Okay, so a brief overview. We're going to have a whistle-stop tour of the evidence base. We'll look at access and referrals. We'll do a quick CI overview and some nice criteria. We'll look at process and outcomes, and then I'll show you briefly some of the resources and support that's out there as well. Okay, we're not going to go into too much depth on this stuff here. It's the kind of thing we already know. We know that there are numerous emotional, social, and economic costs and challenges associated with hearing loss. And we know this number grows year on year, and it's highlighted here by the World Health Organization. We also know that worldwide, approximately less than 5% of people who may benefit from a cochlear implant actually have one, actually even access one. So we know that we've already got a challenge. If we bring this down to perhaps more of a micro level, I quite like this study because it explores the really salient issues that we've seen coming up in the evidence over the last few years. So in 2019, Beerbaum et al. Looked at a group of Australian and UK clinicians and their patients. And what they were trying to do was understand a bit more about the challenges that each group saw, the problems that they saw as part of the referral process. And these were the main themes that came out. There were 55 patients all in all, and they were interviewed along with around 28 clinicians. And what they were doing was really thinking about what their challenges were and then coming up with these particular categories. So we can see then that fear comes up, system and organizational barriers, social barriers, lack of support or knowledge, and perhaps we'd kind of put awareness in that bracket too. And then practical inconvenience. And I'm not sure that's a term that works for me, but I understand it in this context. So if we look at how kind of the biggie first, I guess, fear. Fear of surgery is certainly a big one, and it's something that the audiologists I work with talk a lot around. It's a consistent element that comes up over and over again, and I certainly saw it a lot in my own clinical practice. And bearing in mind I've been out of clinic for nearly a decade, I can still remember the guy's name who I spent hours trying to coax and convince that he could go to the hospital, and it would be at least sensible and sound for him to explore the possibility. But the fear around the surgery took over. It can conjure up so many worries. People think of complications, potential side effects. Trust in medics is a big one. People fear loss of residual hearing. They worry about outcomes and guarantees of seeking that guaranteed outcome. They worry about sound quality or perhaps not being ready enough. I've certainly seen people who have a perception that there will be a huge cost to the device and that would be prohibitive for them. There's lots of discussion as well out there when you really start to dig into CI about the ability to access music post-cochlear implantation because of the way that a CI might be programmed. A lot of this is within the rehab. It can also be the fear that this procedure is seen as a bit of an end of the road point in the realm of audiology, perhaps rather than the beginning of something else. This practical inconvenience term, I'm unsure that I like the phrasing, but I do understand the messaging, sort of. If you think about the nature of how CI centres are set out, and we'll take a little look at a map in a moment. If you think about the geographical travel that some people have to commit to in order to access the surgery, think about the appointments, think about assessments, and perhaps people have a dislike of hospitals. There's perceived inconvenience that accessing things like rehabilitation can be hard. Potentially, if someone's struggled with the use of hearing aids, is there that perception that someone might struggle in the same way with a CI? And also people talk about not wanting to be solely reliant on one device. And for adults, that's certainly an issue because adults only get one. There are social barriers too. The vast majority of adults with a cochlear implant or who are going through assessment don't necessarily perceive themselves as being deaf or as a deaf person. I would often say to people, out there in society, to a large extent, deafness can still mean no speech and sign language. And we know that's wrong. We know that's not true. But if you think about societal perception, that word has so many connotations. So the shift in identity that the surgery could cause might be a barrier too. People might not want to associate themselves with a different sort of experience or a different sort of community. And sometimes as well, people have got very used to their audiology service, what they do, how they're supported, and this can represent a shift, which is scary. It's all sounding very positive, isn't it, at the minute? I think as well, systems and organizational barriers can be really difficult. And we need to note that and acknowledge it and understand it. At BSHAA last week on Friday morning, Katrina did a great talk around referrals. And one thing that I picked up that I really liked that she said was really about the notion of an explanation of at least going to find out. So as a clinician, encouraging your patient, have one appointment, have the one, see how it is, weigh it up, do the cost benefit analysis. Is it worth the travel? Is it worth the inconvenience? And then that's a nice way to be able to narrow down some of those big overwhelming concerns that can mushroom and blow up in those kind of situations. And for the clinician, we know too that there can be barriers to clinicians as well as patients having concerns and barriers about CI in particular. And they're quite similar in their nature when we kind of dig into it a little bit. Some of it is around the concern that discussing a CI and perhaps raising that again in a following appointment might lead to a patient thinking, oh, give me a break, stop, someone becoming disengaged. Or perhaps they'll start to think that this isn't the right place for them. A fear that a patient might feel annoyed or confused by a referral suggestion. I've certainly been in situations, and I'll be very open about it, where I've perhaps been encouraging a patient of mine to seek out referral and they were within referral criteria, whereas I'd have a colleague down the corridor who was perhaps supporting that patient with their hearing aid use, who was saying, no, we're not there yet. We're not there yet. So for that poor patient in the middle, there can be mixed messaging. So how do we as clinicians support the patient, but also support each other in that train of thinking? The system and organizational barriers. So sometimes there can be that kind of lack of continuity. Services and access to services, so rural, remote areas. And access to hearing aid provision, access to testing. Sometimes that can be challenging too. I happened to work in a centre for 20 years where we had an implant centre attached to audiology. It was familiar, it was easy. If I wanted to explain cochlear implantation to someone, I would go around the corridor, I would knock on a door and I would borrow a demo implant to be able to explain it to my patient in front of me. but I appreciate that that was a luxurious position to be in, and we don't all have that. So how do we ensure that we've got some familiarity so that we break down some of those organisational barriers too? I also think there can be a fear to some extent of getting it right every time. And some of audiology education these days is also sort of geared up to that. We follow a strict and appropriate set of guidance, but sometimes that can be really challenging when you're working with a patient with more complex or severe profound needs. And just looking here, and some of these we've already covered really, but when you think about that lack of awareness, it builds potentially to perhaps a bit of a lack of confidence. And we know that when we work with people and we work with patients, confidence is so important, because if we believe it, they'll believe it. So we need to work on that with each other to enable it. Limited networking for hearing aid clinicians with implant centres. The two tend to be quite distinct groups. So how can we bring everyone together? And that's certainly a piece of work that Cochlear and my team really look at. Perceive limited access to info and resources, and limited scope in formal education for audiology. And I would put that in there. But when I think about my own experience of teaching at degree level and at HAD level, really, and even into the STP and kind of M level and beyond, there's minimal content on things like implantable devices. A little bit more so perhaps around bone conduction devices and the nature of scope of practice and conductive loss. But actually, when you really think about it, it's not mandated as such that there's a big exploration into how you support patients with implantable devices in this way. So now that I've cheered you all up and discussed all the challenges and the problems around it, it is important for us to acknowledge that over time, and really over a relatively short space of time, there's been so much work in this area, and we're doing so much to change it. And I'm very excited to be part of that in my role over the last couple of years. So at the risk of kind of plunging us all into even more depths of despair, it's important that we notice this stuff. I don't know if you've seen it at all, and this is just a quick screenshot because it's often the best way to show you kind of back to the evidence. The Circus study, or Cochlear Implant Referral Criteria Report Audit, was published a couple of years ago now, and it highlights those big disparities in access. So we know here that postcodes, age, social and ethnic background were all factors in that individual being referred for a CI. And this is just with adults. So the numbers are quite stark. The initial audit took place over 5 pilot sites in the NHS. And that audit identified 6,000 potential people that should have been referred for a cochlear implant. And we can see here that just over a third had a documented discussion. And then of that third, only 9% of them then went on and had a further referral into an appropriate clinic. And it's a couple of years old. A lot of work has been done in this area to tackle some of those disparities and some of those challenges. But the numbers here are really stark. And it shows us that there's a huge caseload population that haven't had the option that they could have had to support them in their hearing care going forward. I've just put a little note at the end of that slide as well to look out for indicia, which is circa 2. It's the next iteration of this project. And it's been launched already, but I believe that they're still recruiting, and officially the data for that is starting in January. But it's well worth having a look if it's something that you guys are interested in. But I know that they are recruiting for the next pilot sites to be able to explore it in a bit more detail. I'll leave my contact details at the end as well, so that if there's anything you want to chase up, you can do it through there. Okay, so a quick, very rudimentary map, but I like putting this up because it just gives you an idea of where those CI centres are. It also gives you an idea that if you're someone who lives in a relatively rural spot across the UK, you've got some travel to do if you want to have a cochlear implant. You've got a commitment to make. and that can be challenging. I saw a clinic, an audiology clinic recently down in the southeast. And although, if you can see on my slide there are kind of 4 dots across London, there are 4 centres. For them, what they were saying actually was that even for people that lived in what I would presume would be a relatively close distance to London, for a lot of their patients, it was too far to travel, and London was too bamboozling. And a lot of the time, their refusal of a referral was down to the nature of having to travel into the capital city, and all the busyness and the hecticness of having to do that. The challenge that it brings, I guess. It's also worth noting that if you're someone that lives in the sort of very top north of Scotland, so perhaps you're around Inverness or somewhere, you've also got some travel to do, because Kilmarnock, Cross House, the Scottish Cochlear Implant Programme, are situated in Glasgow. So you can imagine that there's a big travel demand. I think I've just saw something pop up in the chat, and I think I can answer it right here. If this is something that you're interested in, so say you walk back into clinic tomorrow and you identify someone and you're thinking, right, where's my local centre? How do I know where to send this person? Here's a useful link to be able to do that. For the sake of time, I won't make us go through it, but essentially if you click on that or use the QR code, what that will do is take you to a Cochlear page that gives you a complete rundown of all the centres. You can also access that through BCIG, who are the British Cochlear Implant Group, and the other manufacturers will do the same. But it's just a way of being able to go, right, I know I've got a person, where am I going to send them? Geographically, where does it make sense? You might also have someone who potentially could go to one or another centre. So having a discussion with them around which one would be preferable would also be helpful too. I've just put this example up here because I like it. It's a good one. More and more services now are standardising their referral processes and sending out pro formas to support referral into their centre. They're standardising the process, and hopefully that's easing access and streamlining it a bit more for clinicians. It also tells you what kind of information that centre is wanting from you. So, for example, there are some centres who will not accept a referral without speech testing. There are other centres that may well accept a referral without speech testing because they will repeat that speech testing as part of an assessment. So it's always worth knowing who your local ones are and setting up that link. And if you're unsure or you want some support in that, please do reach out to me, because we've got them all and we can send them out. But it's so helpful just to be able to link up in that way. Another offer that's out there, and look out for the adverts, and perhaps I can let the Education Working Group know as well. We've set up over the last year some focus group offers, and essentially it's completely free. You come for the day, you meet other people who are interested in cochlear implantation, but you will also meet with the local CI centre. And the idea of that is that they share knowledge, you go through case studies, we do a little bit of work on auditing. We also work with our volunteers with lived experience. We have before now set up some role play sessions where you can work through those kind of counselling conversations as well. But please do keep me posted if you'd like anything like that, and come along. Okay, I'm talking too much, I'm going to whiz through it. Okay. So this is often the slide that everyone copies and is, what's the word, keen to be able to know and keep and hold somewhere. But essentially, this is the nuts and bolts of what you're thinking about when you're working with someone with severe profound loss and you're thinking, am I at a point where I need to refer this person on for a cochlear implant? So for adults, 80 dB, 2 or more frequencies, bilaterally. So essentially, 2 points in the box. If you think about it that way, it's a really nice, neat way to be able to think about it. And then less than 50% on AB words. There's nothing popped up in the chat so far, so I'll keep prattling on. But any questions about that, please do just shout. That's fine. it's an interesting point, because this move happened in 2019. So although we often talk about it as if it's a change in criteria, it's new, it isn't that new anymore. We're 6 years down the road, but it's interesting that it's made a huge shift in those patients that you might now consider for cochlear implantation that you perhaps wouldn't have before. And just to put this into context, across America, the criteria is 60 dB, and across the rest of Europe, it's 70. So we are behind. And if any of you out there have heard of the COACH trial, that trial is looking at the efficacy at 70 dB of hearing aids for severe profound loss versus cochlear implantation for severe profound loss. Yeah. But it's quite stark when you think about it that way, that there are many more people that potentially could be referred and might get benefit. And certainly when I was in clinic and working in CI, there were very few people that would fit a quite minimal criteria. So you were working much more with people who have very, very marked difficulty. And in some ways, this shift in criteria changes our roles, and in some ways makes our roles a bit harder, I think, as well. Okay, so how do they work? What do they do? Another very whistle-stop tour, but essentially what you have, that number one there, is your microphone. And the microphone sits on the sound processor. It's going to pick up the sound, and the processor then converts that into digital information. That information is then transferred through the coil to the implant that's sitting underneath the skin. So you can just see it, you can just make it out on that picture there where that purple 2 is. I suppose, you know, the way that I would usually have approached this in clinic is essentially to say, when they put the implant in, you've got a little hollow here, usually in the mastoid area. And in that hollow is sitting the information that's being transferred through the coil to the implant under the skin. So the implant is sitting in that hollow in the bone. And the two magnets are attracted to each other, and that's how they stay together, and that's how the signal comes through. The implant then sends electrical signals down the electrode and into the cochlea. And then the hearing nerve fibers in the cochlea pick up those signals and send them to the brain, hence giving the sensation of sound. I think the thing to remember here is that when you're thinking about those electrodes curling around a cochlea, if we roughly say that we've got about 13,000 hair cells sitting along a cochlea, that electrical signal is being broken down into 22 chunks. So the implant is doing that same work, but in a very different way to a typical hearing cochlea. And I suppose the thing to also remember is that we're bypassing the use of the hair cells in order to stimulate the auditory nerve in a different way. And here's a little bit of a closer look. So there you have the implant itself, the internal part, and then on the other side of your screen, you've got the on the ear and the off the ear sound processors. And you can just about make out the very curly little snail shell of the electrodes there. And to kind of, it's difficult to give you a sense of size, but it's smaller than your tiny little fingernail. They're incredibly small. And interestingly, when I first joined working with Cochlear, we had a talk from the manufacturing team. And I had all these years in audiology, and I had no understanding that the work of the implant is that delicate, that the actual electrodes of the implant are always made by hand. And that, yeah, just incredibly detailed. It's fascinating stuff. Very clever. And just to highlight this a little bit more, you can see that, and I really wanted this image just so that you could see it on the head, so you've got a kind of idea of what the size looks like. Here, I've used our latest sound processors, so it gives you an idea of where we're at the moment. And you can see here that there's the on-the-ear version and the off-the-ear version. And this is the Nexa sound processor and the Kanso 3 Nexa one. These were brought out earlier this year, so they're brand new. And if you're a tech person, the exciting thing about the Nexa system implant is that it's the first one ever that essentially, and I'm going to say it all wrong, but it's a smart cochlear implant system. So what that means is that it's got upgradable firmware that sits within the implant itself. So the best way to describe that is that you could be in the middle of nowhere, your processor breaks, and in the past, you would have had a way of being able to access a clinic or access some support to then reload your program onto that processor. Whereas now, with this incredibly clever chipset and firmware in the implant itself, you have a blank processor sent to you, you put it on, the implant knows and stores your data, the two talk to each other, and away you go. Clever stuff. Okay. Moving back to more my world of comfort zone and not about the tech. Discussing implants isn't easy, I don't think. It's not easy. And it's particularly not easy if it's not something that we do all the time, if it's not your everyday bread and butter. So that then there can be many reasons to perhaps put it off or avoid it or kind of put it in your notes to do another day. And language barriers make a difference. Cognition makes a difference. If you know that someone's had a challenging medical history, that makes a difference. There are so many elements to that. If you feel like someone could come back with awkward questions, or perhaps you want to kind of dig in and keep going with the hearing aid settings, there's a time factor too. If you open up kind of a conversation around something more complex, do you have the scope to be able to then dig into that conversation as much as you might feel you need to in the time you have? Another factor I think too is as tech changes, as things develop, we will quite rightly question, are they suitable? What if I mention it and I might not be quite right, or I might have got it wrong, or things might have changed? And I think the other question, and something that sort of I've been learning over the last couple of years too, is that clinicians will ask me, well, is it me? Am I able to do this? As an individual practitioner in my own right, with my registration, is this something that's practicably something I can offer? And all of those questions are things that certainly over time I've been asked as part of my kind of daily work. And so these are the things that we have to really unpick. If you can't get to the point where you feel you can answer all their questions, use the resources that are out there. There are so many now, you know, and not just from myself, but from a varied kind of sources as well. Trying hearing aid settings first, that can be completely relevant. We want to make sure that that person's hearing aids are completely optimized. You've completely got them to the end point within your scope of practice and what you can offer them before you're going to refer them on. Having the time, there are resources and so much more support now around having the time. So potentially, even if it's a pack of, you mention it and then you say, please have a look at all of this, we'll talk about it next time. You've put that step in. You've made a move. Are they suitable? What if I mention it, but I'm wrong? What's the worst that can happen on that one? You know, the worst that can happen is that you refer them and the clinic says, for whatever reason, no, at this moment, this person isn't suitable. Please review this, this, and this. Or even it may well be that that person just isn't ready at that particular moment. And you are absolutely able to refer. No matter where you sit within an audiology organisation, it's absolutely your role to refer, always. And even if that means you're in a position where you perhaps have to discharge back to primary care, you can write a letter or a referral into your CI centre when you CC the GP, because that way you close the loop. Okay, what time are we on? I've included this because this is the advice given to the CI champions who sit within the NHS. And essentially that role is a leadership role in audiology. It supports clinics to design pathways, deliver care, support their patients with severe profound loss. And sometimes I think this slide just helps because sometimes I think we feel that we need to know all the answers before we begin. And this itself is a bit of a barrier to implant referral, particularly in busy and hectic clinics. So it's nice to be able to condense this down and just remember that actually those individuals may not hear about it from anyone else. So it does become our role to be that pivot person that sits and initiates the conversation, even if we don't have all the answers. Okay. Process and outcomes. This gives us an idea of the typical thinking and the typical pathway that someone might experience. So we're going from a position of someone making a recognition that they need some support, they need some help. They'll come to you for hearing aids. Hearing deteriorates, we go for some stronger hearing aids. Potentially then an even stronger prescription. And potentially then we're thinking around, okay, what else might we need to do to support this person a bit more fully? They're optimized, but it's not working for them. Then potentially we look at cochlear implantation. We also need to consider for adults, because they only get one on the NICE criteria, unless there are very specific circumstances, which is around dual sensory impairment. We need to be thinking about what we do with the other ear, because we know that if you can maintain stimulation of the other ear, you're more likely to be able to give that more rounded hearing experience, and you're more able to support that patient potentially in the future. So should criteria change, they've had stimulation of that auditory nerve, so they'd be more likely to be able to use a CI in the other ear, should that ever be an occurrence. I think also that the vast majority of bimodal users report that they get a lot of benefit from streaming and from connectivity. So devices like that can be really beneficial too. So it's important for us to consider that as part of our discussions. If you've got an interest in that area at all, please let me know. It's a burgeoning area of work that we're doing at the moment. We had some focus groups earlier this year when we looked at bimodal, and the awareness around counselling for cochlear implantation and that reassurance that you can still have a hearing aid in the other ear, it was quite sparse. And audiology knowledge that you could still have a hearing aid in the other ear was quite sparse. Yeah, so it's something to just have an awareness of and slot into your counselling. So coming back to a CI pathway, what's going to happen when you make that referral? And this is a generalisation, but most of the time, this is the kind of thing that your patient would experience. So they're going to have an assessment appointment, and that assessment may be with audiology, it might be with speech and language therapy, you may have a psychologist, you may also have ENT surgery involved in that, you might have audio vestibular physicians, you may well have things like MRI that sit as part of that. So there are lots and lots of elements that potentially are brought into part of that assessment process. Then you get toward a decision, and usually that decision is made with the patient and the ENT and the surgeon. The standard line is that it will be the surgeon who identifies which ear to go for. In my personal experience, the ENTs were always very good at asking the patient, particularly if there wasn't that much between ears. And it's important. It's an important factor when you think about things like duration of deafness as well. In the middle, we've got surgery. The surgery, again, is something that people I know have concerns and barriers around. And interestingly, in a relatively short space of time, the surgery has gone from an expectation of being an as-a-day case to more like a few hours. And interestingly, there are centres that are also doing the surgery under local anaesthetic now too. So that it changes quite rapidly over time. In terms of programming and switch on, the standard expectation around that would be the switch on of the processor, as long as everything had healed up okay, would be a few weeks. But again, interestingly, there are some centres who are switching on much quicker than that. And certainly are parallels across Europe. In some cases, they're switching people on the next day. So again, a lot of that is around systems and processes. The patient would expect then to come for multiple tuning appointments and programming appointments in order to get it right. So essentially, when you have an implant, they do this thing where they set the map. And what they're doing within that is they're setting the quietest sounds you can hear and the most tolerable loud sounds you can hear. So essentially, they're setting the dynamic range of that map. And they're ensuring that the patient can cope with the exposure to sound that creates. And I'm sure, you know, if you're on this webinar, you've probably already at some point in time watched those very emotive videos of switch-ons where people are saying, oh, it's amazing, or everyone's crying. And sometimes it was like that, but in my experience of working with adults, for the vast majority, it was a slower burn. And people still needed to lip read. They still needed that visual cue support initially to feel comfortable with the sound. And most people would talk about the Mickey Mouse sound, the Donald Duck, the robotic sounds. And a lot of that is, of course, due to that exposure to the high frequencies that they're getting that they may well have not heard for 20, 30 odd years. Okay. And then optimization. So for those patients, they're going to come back. That map is going to be tweaked and tuned in order to optimize it to get it right. And they're going to follow a program of rehabs from there. I'm going to skip this little bit because some of that we have already covered. Predictors of outcome. So for adults, these are really the key factors when we think about how well someone may well do with their implant. Duration of hearing loss or deafness prior to implantation. That's really important because we want someone to be able to use that sound stimulation. We're reliant on their auditory memory and all the files that sit in that auditory memory to be stimulated for them to be able to recognize that sound stimulus, make sense of it, and then do something with it. So in rehab, I would often start with getting someone to detect a sound. So was there a noise? Yes or no? Tell me which noise it is. So is it kind of a crumbly paper sound, or is it a knocking on the desk sound? And then we would work through an auditory hierarchy to a point where someone could follow me, potentially even without lip reading. Residual hearing is important, and more so now in the field of surgery and in the field of implantation. They've become a lot more adept, is probably the right word, at hearing preservation or natural hearing preservation. So there's a focus now on retaining that access to hair cells as much as possible in order to give someone a sensation of natural hearing too. Age at implantation is a factor. The oldest person that I know of in the UK to have a cochlear implant is 103 up in the northwest. So as long as you're physically fit and able and they feel that you can use a cochlear implant, age is no barrier at all. But often we can make an assumption that as someone grows older, it would be too much, it would be too difficult to do. One of my favourite memories is an older chap that we implanted because he was a carer for his wife. I don't know that he was particularly keen on the idea, but he wanted to be able to hear her. And I will always remember he was incredibly shocked that when he went to the bathroom, the sound of the toilet made a noise because he'd forgotten. And he told me this with a very loud voice in front of a packed waiting room. And it was hilarious. But to him, the kind of the joy on his face, it was incredible. It was a new noise to him that he'd forgotten about long ago in his past. Rehab and lip reading is important. So as part of the assessment, they'll really make sure that someone can do the work in order to be able to really work with the sound. One of our brilliant Cochlear volunteers, she has been implanted for a while, but she decided that she really wanted to access music. So she's put a lot of work into training herself to access music, particularly music that she enjoyed from the past. And electrode position and insertion is crucial as well. So we do a lot of work in our technology to be able to support surgeons to get that electrode in the right place. I'm conscious of the time, so I'm going to whiz through it. I've always got too many slides. So when we're thinking about 2 points in the box, and if we suppose that this is a PTA of, let's say, 40-year-old, you've seen them for the last 5 years, you've supported them, they report struggling with aid use a bit more than they have done before, and you notice that they're not following you as easily, more and more so in appointments. Now, at first glance, to me, this wouldn't necessarily have been a PTA that I would have even considered for referral. But if you think about the criteria strictly from a PTA perspective, this is a PTA that sits within CI criteria. Next one. A very different looking audio, but potentially, again, it's worth consideration. And it's something really to just have on your mind when you're thinking about seeing patients with this kind of difficulty. And they're potentially the people that you've been seeing for a while, who may just get to a point where they're struggling more and more. It's also worth kind of keeping those stats about the criteria elsewhere in your mind. You know, if we're thinking about 60 and 70, it may to me, I think it's also worth considering those factors about when you do mention it, because for this person, you might not want to mention it yet, but you might get to a point of considering, okay, well, they've been struggling for the last 5 years. Shall I start to discuss that there are other options and what those other options are? Forewarned is forearmed. And this one is a similar scenario, really. I saw a lady in clinic years ago with a similar loss to this. Her loss was congenital, and she'd had some combination of hearing aiding most of her life, but she'd struggled with them hugely. She was an older lady, and she'd had body-worn devices and various things. And she was an amazing lip reader. And at the time when I saw her in clinic, she wasn't eligible for me to refer her. Now she would be. She'd sit very nicely into that, and she'd probably get really good benefit because she could really work with the sound stimuli that she got and the communication cues that she got. But again, not necessarily someone I would have thought of immediately. Okay, we've got 10 minutes. I'm going to whiz through that one, find the most important ones. Okay. So in terms of resources and support for you and support for your patients, these are the really useful and important things, really, from a Cochlear perspective, that I wanted to highlight and just bring to your attention. Recently, our engagement team, the team that I sit under, have relaunched an offering called Cochlear Compass. And the idea of that really is that we want to try to help you and your patients and support you as a combined unit, if you like, across the pathway. So what might happen, arguably, is that, say, someone contacts us and says, I really want a cochlear implant, am I in criteria? And we will then try and support that person to understand cochlear implantation a bit better, essentially. So when that patient is motivated for change, they may well start to investigate their hearing options by contacting yourselves, contacting an organisation like us, really just starting to understand and explore what their options are. The beauty of them contacting and working with us, and probably my favourite part really, is our group of people with lived experience who we offer connection with that they can then support. So we have a wonderful group of volunteers, and our volunteers will, if a person comes through and they want some extra support, what we will do is set up a connection between those two people, and then Cochlear step out. So the idea is that someone with lived experience who's been through it can explain all the more tricky stuff, the questions that perhaps they don't want to ask in clinic. And our Cochlear volunteers are incredibly passionate about the support that they offer as mentors too. But it just gives you a bit of an idea of the kind of things that they get up to. So we'll have the one-to-one support, but they'll also come in and support our education, professional education sessions. They work in advocacy, and they're great as well for us to bring in to support us when we go out and speak to audiology too. And I know that as part of this series, Jayne very kindly let me see a video that she's recorded with one of her fantastic patients who went on to have a cochlear implant. And hearing it from someone who's been through it is probably the most crucial factor in any learning you can do around CI. So important. I want to say a big thank you to Jayne for that as well, because she also talks candidly about her experience as an audiologist and as a referrer going through that process. So not only perhaps feeling like you have to kind of let go of the reins a little bit in supporting your patient, but also then what you get back from the referral centre. So this is just a little shot of our team. And essentially there are just these three elements. So professional support, which is part of what we're doing today really. Cochlear Compass, so that's all around audiology signposting, helping patients that get in touch with ways of understanding who to go to, where to go to and for what, and our volunteer programme too. As part of what we have in the resources is this lovely video. It's not very long, so I'll play it quickly. But essentially the video, I think you can just about make that out, sits in this ebook as a resource for clinics. The video itself is 4 minutes long, so I won't take up our precious time. But if it's something that you're interested in for clinic, get in touch with me and then we can organise getting them out to you. I really like these because if you're stuck for the words or you're perhaps feeling a bit pushed for time, a quick 4-minute video that was developed by our volunteers gives you enough information to go on that isn't too in-depth, but it's a way of being able to explain it quite neatly and quite quickly. Okay, just gives you an idea of the content. Those patient information videos have proved invaluable, but our marketing team did a great job with those, and they're very helpful. Another option is that QR code that I'm showing you on the screen sits on a little postcard. So if that's something that you wanted to be able to access in a clinic, or perhaps you're out and about, that sits on YouTube, so it's an easy access one as well. It's the same video, just accessed in a slightly different way is all. A little bit more info in terms of brochures. There's so many resources out there, so please do just get in touch. That's our joint email address at the top there, but I'll also give you my own one as well. A few QR codes to use. So if you wanted to access any more online learning, we have the peer network. There are some modules for CPD on there, around 6 of them. 4 of them are on CI and 2 are on bone conduction. There's also, if it's your cup of tea, a video about surgery as well, and a few other webinars that sit on there too. And we've just recently launched the CI referral guide website, and that was at BSHAA, so I thought I'd put that up as well. And equally, the green one is for any patients that you might have who you want to send in to have support from our lived experience volunteers. That QR code will take them to them. Okay. And with 4 minutes to spare, here's my email address. Please do feel free to get in touch if you wanted to. Always more than happy to help in any which way we can. Okay. I'll put on the any questions slide.
Thank you, Charlotte.
Yeah, thank you very much.
Pleasure. Shall I open the chat and see what?
Yes, yeah.
There are some questions that have come in. I've got a question asking, I believe this is in regards to the assessment. Is it still an aided word list score?
The answer is yes. Yes, it is.
Simple answer?
Yes, it is exactly that.
Okay. And in case of bimodal, do you share the platform with a specific brand of hearing aids?
Yes, Cochlear have what we call a strategic hearing alliance with GN Resound, and the beauty of that is that we're not reliant on each other as an organisation. However, we always ensure that when we develop new products, we work together. So essentially, the bimodal offering with a Cochlear device will always be a GN supported device on the other ear. And the other manufacturers have other ones. Interested in any of all the resources in it? Great, thank you, Hazel. I'll reach out. A comment about the postcard. Most of the patients I've given loved it. Oh, great.
Very good.
What's a typical WR improvement with a CI? What's WR? Am I being daft?
Is that word recall or what?
Word recognition.
Thank you. Yeah, word recognition. You're right. Yeah. Emily, it's a really difficult question to ask in that there are so many dependent factors. So there isn't really a typical word recognition score. What you would hope for is that someone makes rehab progress within around about 3 months. And usually what you see is that they kind of reach a plateau at around about 12 months. But in terms of word recognition, you could have someone who perhaps, I don't know, was on an AB word score of maybe 30. If I'm thinking about one of the experience of one of our volunteers in particular, he was around that mark, and he was really pleased to tell me the last time we met that his AB word score was something like 98%, about 6 months post implant. So it does vary. It's difficult to give you a definitive answer on that one because it's so subjective and dependent on the patient and their experience. Yeah. A hybrid CI, yes, absolutely. Yes, is the answer to that one.
Thank you, Charlotte. Appreciate that.
Okay, any more questions? Look at us, we're bang on 7 o'clock.
Thank you so much, Charlotte. I'm sure everyone will agree that was massively informative and hopefully given our members the little bit more information to guide their customers. Yeah, and obviously we can reach out to you, and we probably would like to follow it up with some more webinars down the line, I'm sure.
Please do. Yes, it's really enjoyable, and thank you all for your support. And yeah, the education working group have been brilliant. Very organised, very dedicated. Yeah, kept me on track, which is what I need. But no, it's been lovely. Thank you very much for having me. Also, more than happy to do more work with you guys, and perhaps next time we can think about having an opportunity of a webinar where I can bring in perhaps one of our volunteers with lived experience as well. And and we can start to kind of hear their voice too in what we do.
Yeah, that would be fabulous.
Absolutely.
Thank you.
Wonderful.
Thank you, Charlotte.
Okay, thanks all.
All right,
Thank
you.
Thank you, and thank you for all the contributions in the chat and the questions as well. I really appreciate it.
Brilliant.
Thank you.
Thanks. Have a good Monday
Okay.
evening.
Yes, you too. Thank you. Good night.
Bye-bye.
Bye.
Thank
Bye.
you.